Good morning, everyone. Thank you for joining us for this early bird webinar, our first early bird after summer. In partnership with Merck Sharp and Dumb, my name is Dwayne Schultes. I'm the Managing Director of Vital Transformation. I'll be moderating today, and we'll be discussing diagnosed but not treated, prioritizing timely care in Europe's cancer plans. And thank you very much for joining us today. If you're having connectivity issues, problems with your bandwidth, please push this little button next to the mute figure on your menu. This menu item will pop up and you can switch to the phone. We've provided several dozen phone numbers for you. We absolutely want your participation in this webinar. So please go ahead and switch to the phones if you're having connection problems. And we're taking your questions. This is a short webinar. An early bird is only 30 minutes. So please get in early if you have a question. We have great speakers. So please push this little Q&A. The menu will pop up. You can submit your questions and I'll submit them to our panelists as we move through today. And again, thank you for being here. So timely access to optimal treatment has great promise for significantly improving outcomes for cancer patients. The early diagnosis and treatment of skin cancer provides a 99% chance of 5-year survival. Yet in later stages, the odds drop to just 27%. The length of time it takes for cancer treatments to reach patients is vitally important to policies, including Europe's Beating Cancer Plan. Ineligibility requirements, late diagnostic testing, treatment delays, poorly defined clinical guidelines, and resource constraints worsen a patient's access to timely and adequate care. How can we ensure that patients are diagnosed promptly and can access treatment in a timely fashion? Why does reimbursement not always correlate to access to innovative treatments across Europe after HTA approval? And how should we prioritize treatment rates in cancer plans? And again, I'm very pleased to have a couple excellent speakers with us today. I'd like to introduce to you now Thomas Hofmarker from the Swedish Institute for Health Economics. Good morning, Thomas. How are you doing today?
Good morning. It's a pleasure to be here.
Pleasure to see you too. And also Mike Morrissey, the Chief Executive of the European Cancer Organization. Mike, always a pleasure to see you, sir. How are you doing?
Good morning, Dwayne. Morning, Thomas. Good morning, everyone at home.
Thank you very much. So we've had, 100 plus people join today, so we should have a lively discussion. Thomas, I'd like to start with you. You recently worked on a research paper that looked at diagnostic access and cancer treatment access after what we traditionally think is the bottleneck, which is HTA approval. Now, this is really interesting. Can you go through some of the top line findings of your study and some of the key things that you think we need to look at today?
Sure, absolutely. So indeed, we looked at access to anti-cancer drug treatment of lung cancer patients in Europe. And more specifically, we looked at patients with advanced non-small cell lung cancer, for which drug treatment is really the recommended treatment option. And if I would have asked myself before conducting this research project, do I want to be a patient with advanced non-small cell lung cancer in Portugal or in the UK, I probably would have said the UK. But it turns out that Portugal seems to do much better. So in Portugal, according to our research, 80% of patients receive drug treatment, 80%, compared to only 40% in the UK. So there's huge variations across Europe when it comes to drug treatment in that patient group. And then the question is naturally, why? Why do we see these differences? Why are patients not getting treated? Even though the treatments themselves used to be old chemotherapy drugs, which now should have been replaced by immunotherapy and targeted therapy. So the issue is not necessarily that drugs are not reimbursed on a national level. It's really about patients who have received a diagnosis and who are recommended to receive drug treatment according to European guidelines by ESMO, the European Society for Medical Oncology, but who just don't get it. And the main reason, according to our research, are long delays in the time from diagnosis to treatment initiation. And here we're talking about several weeks or even several months. And lung cancer is one of the cancer types that tends to progress quickly. So you really get sicker by the day. And long delays might just make you too sick to be able to treatment that you could have gotten if the things would have been more smoothly and faster. And the main delay is really caused by diagnostic testing. So here it's really about obtaining tumor tissue and then performing analysis of the tumor tissue in order to administer personalized medicine nowadays. And that can take several weeks because we're lacking pathologists. We're lacking pathologists all across Europe. So this is one of the main main bottlenecks. And without the testing done by pathologists, you cannot move on to reaching a treatment decision. And even, reaching a treatment decision can take 1 or 2 weeks because there's some coordination going on. And once you have a treatment decision, it might take another week or even more until you start with treatment, because you might have to be referred from a general local hospital to a specialized hospital. So delays are an issue, but even apart from delays, what we have found is that, for instance, national clinical guidelines might exclude some patients from receiving treatment. They just say, well, we don't treat this patient group, even though European guidelines would suggest that they derive benefit from getting treated. And then finally, it's also about patients who refuse to get treatment. So for some reason, they choose not to receive treatment. That also varies a lot across Europe, also across socioeconomic groups within a country, I should say. So in sum, there are several different reasons for why patients miss out on recommended drug treatment, really.
Yeah, I'd like to drill into some of those patients who refuse treatment later. I think that's a really interesting topic. And again, just to remind everyone who's with us today, please submit your questions. We have a couple of great panelists here. Just push the little Q&A button and we'll take your questions and feed them through as we move forward. Now, Mike, boy, a lot to chew on there with what's going on and what Thomas was mentioning. The one thing that jumps out is this issue of lack of pathologists and the inability to get diagnostics taken under hand here quickly. From your perspective at ECO, are these things being addressed in the context of the European cancer plans and some of the national plans, or does something else need to be done? From your perspective, how do we start dealing with these bottlenecks practically from the patient perspective?
Well, I mean, at ECO, we're very supportive of the Beating Cancer Plan and the focus on cancer by the European Union and at the moment, and the focus on reducing inequalities across member states and within member states. But probably the cancer workforce issue has been treated somewhat lightly by the Beating Cancer Plan. There's probably more emphasis, more work to do. We have a cancer workforce network within our organization. And I think it's fair to say that we probably don't know enough in terms of data on workforce shortages. Pathologists, I think, is a well-recognized problem and has been for some time, but the importance of the cancer workforce is obviously extremely important. And we know that the Commission wants to do more in this area in terms of training, in terms of sharing experience cross-border, but that investment is really needed. And the data to know where the shortages are and why they're there is extremely important. But because I think you've got two aspects of this. You've got healthcare systems that are very robust, very resilient, and have an urgency about them, an urgency about their default. Cancer is all about the fight against the clock, right? And we know that we have patients who are late in presenting, so that time issue is really important. Some healthcare systems, the way that they operate demonstrates urgency, and others do not, and that can be within the same country, within the same city. You can see that kind of variation. And to be able to address some of that, patients need to be, and their loved ones need to feel empowered. They need to ask the right questions. They need to be provoking a conversation in many cases. Should it be like that? Probably not, but that's the reality. And if you look at the European Code of Cancer Practice, which is 10 patient rights, and you look at the first one on europeancancer.org/code, you'll see that an equal access to affordable and optimal cancer care is number one. So the access issue and the time issue is extremely important, and we need to not just focus on the systems and the shortages in workforce that you say, but we need to empower patients and their loved ones to ask the right questions to be able to get that care. I also think that there is generally speaking in healthcare systems, there's not enough done to support healthcare professionals in dealing with their work. Too often, healthcare professionals are dragged away from their time with patients and diagnosis to admin, operational, supply chain, all that sort of stuff. So it's not just about dealing with the shortages, it's about dealing with maximizing the time of healthcare professionals, whether they're pathologists, pharmacists, nurses, whatever.
And just to be clear here, Thomas and Mike, we're not talking about bottlenecks or things that have been caused by COVID, correct? I mean, these are things that exist outside of the already challenges that we're facing due to the issues related to COVID-19. Is that correct in my assumption, Thomas? I mean,
yeah, that's right. No, I mean, the issue of shortages in pathologists or other different medical specialties has existed already before COVID, but COVID has made it many times worse.
And Mike, there's a couple good case studies here. I mean, obviously there's some of the national cancer plans, the German cancer plan, that they're really trying to focus on integrated care. There's some really good examples of integrated care in your neck of the woods. If we're looking at specifically some things like breast cancer that became very politically motivated about 15 years ago, where they became very heavily, there was a lot of political action around it, around the rejection of a specific therapy that had come in, and then people became very activated. Can you tell us a bit about some of those case studies that you're aware of?
Yeah, I mean, I unfortunately have a loved one who has recently had breast cancer, and in her case, it was brilliant. Her local healthcare system in the UK actually did this sort of one-stop shop when she'd been referred by her GP, one-stop shop, biopsy, mammogram, comparison with the previous mammogram, all in one place at one time, with an oncology nurse on hand to support her. Diagnosis very quickly afterwards, operated on quickly afterwards. I think the whole thing took 3 to 4 weeks. And I was relaying that to some of my colleagues, oncologists, medical oncologists and others at ECO, and they were saying, wow, that's pretty impressive, because even in other very good healthcare systems in Western Europe, it could be 3 times, 4 times that time, just because of some of the shortages and some of the delays that Thomas was outlining earlier.
And again, this is a question of political will. Thomas, how much variance is there? I mean, when we're talking numbers here, how big are the variants? I mean, we've heard about a 3-week example here. What are some of the other examples on the other way? I mean, how long can some of this stuff take?
I mean, it really depends. I mean, if you're super unlucky, then, for instance, when you have to be referred from a general hospital, which did the diagnostic workup, to a specialized hospital, some of the tests that you have already been doing might have to be repeated. So again, this takes a lot of time. So it's really about, taking several months really for you from diagnosis to getting treatment. And I mean, it's really a very difficult situation for patients and their loved ones, just waiting for things to happen.
We have a question here from Mark Dooms. Mark, thank you very much for your question. Mark says, we now have European reference networks, and he includes the link, and other networks as well. Is this helpful? Mike, I know that we're putting in place several benchmarking exercises and things like that. Are the European reference networks, is this part of the scope that you're looking at ECO?
Oh, definitely. And I think that's one example of how some of these issues can be tackled. I think, we had a meeting of our inequalities network on Monday this week, together with OECD, that have been charged with developing the Cancer Inequalities Registry, which is part of the Beating Cancer Plan. And we were exchanging on that and what should be included and how to go about it. Because the reality is, without people like Thomas, without data, we wouldn't know some of this stuff. We wouldn't be having this conversation. Now, we know anecdotally that there are wide variations in the quality of cancer care in Europe, but we really need to analyze the data, and sometimes the data just isn't there. And what we hope, and we've been calling for some sort of dashboard or measurement for some time now, to make sure that the Beating Cancer Plan delivers on its mission. And we think that the measurement is just so important. COVID, I think I very much agree with what Thomas said about COVID. COVID shone a light on pre-existing problems, and our job is not to just recover from COVID. It's to build back to a much better healthcare system in light of what we'd learned from COVID.
And picking up on that with COVID, Thomas, have we caught up now from those bottlenecks created by COVID? Has the deck basically been clear now? Are we back to operational capacity, which would be, from what your study says, probably somewhat less than suboptimal to begin with, but are we at least to the normal suboptimal level of operation now?
No, we're not. And it really differs across Europe also. I mean, if you look at Bulgaria and Romania at the moment, COVID numbers have spiked again. So
yeah,
hospitals are overcrowded. But even in other countries, like I talked to oncologists last week in Ireland, and there they say, well, the situation is better, but we're still having this backlog. So the delays we're having at the moment are still longer than we had before the crisis, just because we haven't caught up completely yet.
And Mike, from the patient perspective, is this what you're hearing from your members and feedback?
Yeah, I mean, we have this Time to Act campaign that we did in 30 languages across Europe, emphasizing the importance of acting in a timely way, because people were more scared of COVID than they were of cancer. And,
sure.
And healthcare systems weren't robust enough. There were, the data study that we did showed that there were 1 million people probably in Europe during the COVID period with undiagnosed cancer because of 100 million missed screening tests, for example. So that obviously takes time to recover from. Of course, I think it is fair to say that people are having more confidence in seeing their doctors than they were at the height of COVID. But I think that it will take quite a long time, years rather than months, for the whole of Europe to recover. But again, we're advocating for the fact that it shouldn't just be about getting to where we were. Where we were, as you indicated, Dwayne, isn't good enough. But we're optimists too, Dwayne.
Sure.
We think that the investment of resource, not only money, but the investment and the prioritization of cancer within the European Union's agenda is amazing. It's magnificent. 40 odd initiatives in the Beating Cancer Plan. Let's hope it can be really well coordinated. But people working in cancer have been calling for this for years, and it's like waiting for a bus and getting 10 in a row. We've got a responsibility. We've got a responsibility to make this work, regardless of the challenges.
Sure. And how far along are we in the dashboard right now? What's the deliverable, and when do we think that we're going to start seeing some results of that work? Mike, I'll take that to you. Sorry.
Sure. Well, the OECD meeting was very impressive in that we had a wide range of people, from oncologists, nurses, pharmacists. We had a number of patient advocates, and we had representatives of charities and the healthcare industry. So it was an all-inclusive conversation with OECD, and they are only in the preparation stage for the registry. Of course, what we've been calling for in the dashboard and what ends up being in the registry aren't necessarily the same thing. Because I think there is a political concern that this doesn't turn into a yellow and red card system.
Right.
Would not go down well with member states, and that's not what we want. We just want there to be a political interest in monitoring the progress of the Beating Cancer Plan, because if we get some of these 40 initiatives right, you will see in the short term even some improvements and reduction in the inequalities that exist across Europe.
Thank you, Mike. We have a question here from a Magdalena Petrulesa. Thank you, Magdalena, for your question. Again, we've touched on it a little bit, but this gets into dichotomies here. Did the study identify evidence on the pandemic affecting access to imaging diagnostic CT and bronchoscopy? So, stomach cancer, throat cancers, and diagnostic CT. Thomas, anything specifically on imaging and some of these other diagnostic treatments?
Yeah. I mean, of course, like during the height of the pandemic, the first outbreak in April and May, obviously, like access to all of these services was highly restricted. So of course, now things are getting better, but back then it was very difficult, obviously. Yeah.
Okay.
But I wanted to say a little bit about what Mike said, comment on that, work with the dashboard, but also the European Cancer Inequalities Registry. because I mean, one of the initiatives in the Beating Cancer Plan is really saying that we should have cancer diagnostics and treatment for all. That's the name of an initiative. But our research really shows that maybe that's not the case, and I'm worried that we're not going to measure this really in the inequalities registry or in the dashboard, because I have not really heard this sort of metric that we did, so that a treatment rate in these discussions. And I think it's really important because that's really what matters to patients. So you really start comparing patients who receive treatment to the patients who are recommended to receive treatment. I mean, that's why we have clinical guidelines telling us who to treat and whom not to treat. But then we also need to measure it if we want to achieve this goal of having access to diagnostics and treatment for all.
But one of the problems, and again, getting to the politics around this, if you look at the UK a few years ago started publishing outcomes results of the various hospital trusts around the UK, and it caused a firestorm politically. There was enormous pushback, mostly from the medical practitioner community. How do we do this in such a way that the actual people that end up getting potentially named and shamed don't take it personally and push back against this, because that's going to be counterproductive too? How do we make that balance, Thomas?
So I'm not good with politics, but I believe in data, in the power of data. And if I see charts from the UK trusts really with massive variation across the countries, I'm not just looking at the extreme outliers, but just like 25% percentile against 75% percentile. It really makes me wonder what's going on. And the good thing I would say in the UK is that they made an effort to try to measure things. So that's step number one. But then step number two is also to take actions, to concrete actions that will help solve the issue. And that's where I think we're struggling a bit.
Yeah, Mike, please.
Well, I think it's got to be more carrot than stick.
Right.
Having a stick in the political context of member states and national competence and all the rest of it isn't gonna help. So the tone of how this is done is extremely important. And I think again it's back to patient empowerment. It's got to be public facing. It can't be something that only experts like Thomas can understand. It's got to be something that even people like me can understand. And that's the reality of it. It's got to be something where patients feel and their loved ones and citizens generally feel that there is something there that they can look at to understand how things have improved thanks to the European Union's investment. Let's face it, prioritizing cancer is a political choice, and it's meant to demonstrate that working across borders is better for healthcare than not doing so. And that has been very much tested during the COVID period, particularly in the initial responses and the terrible situation in Italy, particularly in the vaccination program, which now the European Union has really caught up on and is doing well on. So the EU has a political interest in making sure that this is prioritized. This demonstrates the importance of cross-border experience and sharing of resources, and data can just shine a light on where that needs to be adjusted and improved.
Thank you. And just to remind our audience, we just have a few minutes left here. If you want to get some questions in, we'd be happy to take them, and I'll try and squeeze them in. I'd like to bring up this issue of health literacy. I know this is beaten to death and it's often talked about, but the reality is, Mike, if you look at what you were discussing with this 3-week turnaround in breast cancer treatment to actual surgery, I mean, that's a question of patient engagement and literacy driving the system to change. And then on the other side of the coin, Thomas, your earlier example of people refusing lung cancer treatment because they feel personally responsible, often around the dialogue of, cancer kill, smoking kills, and the sort of negative connotations around that as well they're very literate of their own responsibility to the point where they're refusing treatment. How do we do better around health literacy so we get more of the first example and less of the second example? Mike, do you want to take a crack at that? I mean, what do we need to do, and how is ECO engaged in that?
Yeah, it obviously is a difficult thing, particularly across Europe, and access to headline information in many languages is obviously a key, and that's what we try to do with the European Code of Cancer Practice. But But there is this reality that, smoking kills on a cigarette packet turns into a sense of guilt, a sense of shame by many lung cancer people who get diagnosed eventually with lung cancer presenting late. We know how all of that ends up. So we need
and refuse, in many ways, refusing diagnostics or not getting in and getting checked as well.
Yeah, and many men doing their usual, keeping their heads in the sand and ignoring the symptoms. Of course, during COVID, that's been a challenge particularly. So I think there is this balance to be struck between the way that we message prevention and our tone there with access to treatment. I was very struck by the fact that James Brokenshire, a British cabinet minister who died, I think last week at the age of 53, the media felt the need to mention he was a non-smoker in the fact that he died of lung cancer. And that demonstrates probably a default that we all have, which is if somebody's got lung cancer, oh, were they a smoker? It's almost like an immediate question. So we need to deal with that shame. But I think this question, this point about what questions to ask, I mean, the three of us know people who are experts in all sorts of cancer. What about other people? What about most people who don't know an oncologist and who wouldn't know where to go for questions? We've tried to put together some basic questions for someone who's diagnosed with cancer to ask, but many times they are so shocked by the diagnosis or so impacted by it, they're not thinking about asking questions, and they're the conversations we need to have happen.
Thomas, is there any metrics on effective patient literacy? Is there anything that's been done on this and how we can improve it?
No, I mean, that's really a hard nut to crack. I mean, with health literacy, you've seen it with COVID, the vaccines, the evidence is there, it helps, but then people still don't want it. But I mean, generally, when it comes to health literacy and patients who have been diagnosed and then have received a treatment decision by their physician, but then they choose not to get it, I think the responsibility is also on the physician, trying to explain to the patients the importance of receiving treatment and really explaining in a plain language the benefits of receiving treatment and how this has changed in many cancer types, not just in lung cancer, over the last couple of years with modern cancer treatments like immunotherapy and targeted therapy, providing very different and much better outcomes than what we had 10 or 20 years ago, when maybe one of your relatives that who got cancer got treated. So I think just also updating the minds of patients, bringing them up to speed to all of the advances that we have seen over the years, that's really important.
Thank you, gentlemen. We've just got just a couple minutes left here. Unfortunately, it just goes so fast, these early birds. If I could just get your perspectives on quickly, if you could implement something now today to make a change and improve these bottlenecks and access, what would you do? What do you recommend? Mike, from ECO's perspective, what would be the first thing you try to tackle here quickly to try and get a quick win?
I think the bringing together of existing measures in one dashboard or registry or whatever you call it will make life a lot easier. We've been saying for a long time now, let's not reinvent the wheel. Let's not start again with a new initiative that takes 10 years to launch. So let's act fast. Let's bring together all the expertise that exists already. And let's not forget as well that early detection is not only about screening. There's a whole load of technologies, and I'm not an expert, but the whole question of risk stratification, knowing whose genomics that make them more likely to suffer from cancer in the future. There's a whole innovation piece in early detection which has got nothing to do with screening, which we mustn't lose sight of as we continue this debate.
That's great. And Thomas, same question to you. If we could do one thing from a health economic perspective, from your perspective, what's the low-hanging fruit? What's the quickest win to actually improve this diagnostic and treatment gap?
Yeah, we would need more pathologists, frankly speaking, but it takes time to train pathologists, several years. So trying to bring in more artificial intelligence to support their work in order to reduce the burden on them might be a way to help them to address the shortages we have right now.
Well, if anyone's out in the audience who's been listening today, if you're looking at going into medical school, maybe pathology is a good pathway for you to take in the short run instead of investment banking and engineering. Thomas, thank you very much. Always a pleasure, sir.
Thank you.
Mike, always a pleasure. Great to see you again. And our audience, thank you very much for our first Early Bird after summer. It's been great to be with you, and we look forward to seeing you again. Have a good afternoon, everyone. Good morning, and goodbye.